Welcome to the Deep Dive. Today we're tackling a really critical topic for anyone working in veterinary practice, dystocia.
That's right. Difficult birth in dogs and cats.
Yeah, exactly. It's one of those situations that, well, it demands quick thinking and confident action.
Absolutely.
So our goal with this deep dive is really to equip you, our listeners, with the essential knowledge you need to, navigate these challenging cases effectively.
We've basically sifted through the latest research, clinical insights, trying to bring you a concise but comprehensive overview.
Something you can actually apply right away to improve outcomes for your patients.
That's the plan. Our mission today is really to pull out the most critical info about dystocia from our sources and frame it in a way that's, well, genuinely useful in your day-to-day practice.
We want this to be your kind of go-to understanding for how to recognize, diagnose, and manage dystocia confidently.
Yeah, benefiting both the mom and the offspring, ultimately.
Okay, so let's dive right in. When we talk about dystocia, what exactly are we defining there?
Well, at its simplest, dystocia just means a difficult birth. Plain and simple.
Okay.
And that difficulty, it can stem from the mother, from the fetus, or maybe a combination of both.
And it can happen anytime during labor.
Any stage, yeah. A really common underlying factor we see is an issue with how the fetus is actually presenting in the birth canal. So its presentation, its posture, or just its overall position.
That makes sense.
Yeah.
So maybe before we get into the abnormal, we should probably lay out what normal labor looks like, right, to have a baseline.
Absolutely. That's essential. Normal labor, it's generally broken down into 3 stages.
Okay.
Stage 1, that involves the start of uterine contractions and the cervix starting to relax, to open up.
Right.
And that phase ends when the first fluid-filled sac, the choriolentoic sac, actually ruptures.
Okay, and how long does that typically take?
In dogs, it averages around, say, 6 to 12 hours. But you should know, first-time mothers, primiparous bitches, they can sometimes go longer, maybe up to 36 hours.
Wow, okay.
And during this time, behaviorally, you might see them being restless, nervous, maybe shivering, panting, pacing, doing that nesting behavior.
And what about cats? Is it similar?
Cats are a bit different. Stage 1 often starts with more vocalization, but then that often shifts to purring and wanting more social interaction.
Interesting.
Yeah, and the duration in queens, it's notoriously variable. Our sources really highlight this. It could be as short as 4 hours or stretch out to 42 hours.
42.
Yeah, and sometimes even up to 3 days in some cases. It's a huge range.
That massive range in cats is definitely something crucial to remember when talking to owners, isn't it?
Definitely.
Okay, so what happens once we move past stage 1 into stage 2?
Stage 2, that's the main event, really, the active delivery of the fetuses.
Right.
In bitches, you'll see much more obvious forceful abdominal contractions. Now, typically, the time from when those strong contractions start to the first puppy arriving should be less than 4 hours. That's a key time frame.
Less than 4 hours for the first one. Okay.
And after that first pup, the others usually follow at intervals of, say, 20 to 60 minutes. Though sometimes those gaps can stretch out a bit, maybe to 2 or even 3 hours between pups.
Okay. And for queens?
For queens, the whole process of delivering all the kittens, which is essentially stage 2, averages about 16 hours. But again, like stage 1, there's that big range our sources mention, 4 to 42 hours.
Still that huge variability.
Exactly. And it's really important to remember the total number of fetuses in the litter directly impacts how long stage 2 and the next stage 3, will actually last.
Makes sense. So speaking of stage 3, what's happening there?
Stage 3 is the expulsion of the fetal membranes. So the placentas, basically.
Got it.
And in litters with multiple fetuses, stages 2 and 3 can kind of overlap or alternate. You might see a puppy or kitten delivered, then its placenta comes out right after, then the next one is born, and so on.
Okay, so you get fetus, placenta, fetus, placenta.
Sometimes, yeah. Or maybe a couple of fetuses, then a couple of placentas. It varies.
Right. So keeping these normal timelines and processes in mind, when should you, as a clinician, start getting concerned that things aren't right? That maybe dystocia is happening, and I guess how common is it?
That's the million-dollar question, isn't it? In dogs, getting an exact incidence rate is tricky. There's just so much breed variation, and breeders often step in early.
Right.
But in cats, we actually have some better data. Studies suggest dystocia happens in about 3.3% to maybe 5.8% of all cat births.
Okay, that's quite specific.
Yeah, and what's really interesting is the difference between mixed breeds and purebreds. It's quite low in make breeds, maybe only 0.4%.
Wow.
but it jumps way up in some pedigree breeds. Like the Devon Rex, sources mention rates as high as 18.2%.
Whoa, 18%. That's a massive difference.
It really is striking.
Are there other specific breeds in both dogs and cats that we should be particularly watching out for?
Oh, absolutely. Breed predisposition is a big factor. In dogs, you see it more in miniature and small breeds. Sometimes that's down to small litters with relatively big fetuses. But paradoxically, also large breeds, especially if they have like a huge singleton puppy or just a very small litter. And then, of course, the brachycephalic breeds, the flat-faced ones, their broad heads and often narrower pelvises are a classic setup for problems.
Right, the conformation issue.
Exactly. And our sources also flag that fetal head-to-pelvis size ratio specifically in breeds like Sealyham and Scottish Terriers.
Interesting.
Plus, certain breeds just seem prone to uterine inertia where the uterus doesn't contract effectively. That includes Scottish Terriers again, Dachshunds, Border Terriers, Aberdeen Terriers, even Labradors.
Okay.
And then there's a whole list of others often mentioned. Chihuahuas, Pekingese, Yorkies, miniature poodles, Pomeranians.
Quite a few common small breeds there.
Yeah, and in cats, again, the brachycephalics, Persians, Himalayans are higher risk. And also, as we mentioned, the dolichocephalic Devon Rex. It's interesting, some sources suggest these pedigree lines might have linked skeletal conformation issues contributing beyond just the breed standard looks.
That's fascinating. So knowing those breed risks definitely helps keep our index of suspicion higher for certain patients. Let's shift gears slightly to actually recognizing it when it's happening. What are some key things an owner might report historical findings that should immediately set off alarm bells for us clinicians?
Okay, yes, the history is crucial. One major red flag is seeing more than 30 minutes of persistent, really strong abdominal contractions, but no puppy or kitten is produced.
Okay, 30 minutes of hard pushing with no result.
Exactly. In bitches, specifically, if it's been more than 4 hours since you were sure stage 2 started, the act of pushing began and still no first puppy, that's a concern.
4 hours from start to first pup. Got it.
Or if the time between puppies stretches out to more than 2 hours, that's another key interval for bitches.
But 2 hours between pups, okay.
Also, timing relative to pre-labor signs. If a bitch doesn't start stage 1 labor within 24 hours after her rectal temperature drops below, say, 37.2 Celsius or 99 Fahrenheit, or within 36 hours after her serum progesterone drops below 2 ng/ml, if you happen to have that measurement, that's also a warning sign.
Okay, those are useful benchmarks.
And behaviorally, if the female is crying excessively, showing obvious signs of severe pain, or constantly licking her vulva during contraction without making any progress, that suggests something's wrong.
Pain beyond what seems normal.
Right. And finally, just a prolonged gestation overall. So for a bitch, if it's gone past 72 days from the first mating, or maybe more precisely, over 59 days from the first day of cytologic diestrus, or over 66 days from the LH peak.
If you have that data.
If you have it, yes. Or for a queen, if it's gone past 68 days from the last known mating. Those prolonged gestations definitely warrant investigation.
Those are really clear, quantifiable timelines and behaviors for vets to educate owners about and to watch for themselves. What about findings on our own physical exam? Are there specific signs that scream dystocia?
Yes, definitely. A big one is seeing a greenish-black vaginal discharge. That's called uterovertin. If you see that more than 2 hours before the first fetus is born, or if you see increasing amounts of it before any delivery, that's concerning. It suggests placental separation.
Got it. Green-black discharge is bad news early on.
Pretty much. Similarly, seeing fresh, red, bloody discharge before the first fetus arrives is also abnormal and needs looking into.
Oh, okay.
And then there's the Ferguson's reflex. That's the reflex straining you should get when you apply gentle pressure to the dorsal vaginal wall during a vaginal exam.
Right.
If that reflex is diminished or completely absent, it's a strong indicator of uterine inertia. Especially if oxytocin isn't working, it points towards inertia rather than just a blockage, unless, the blockage has been there a long time.
Okay, that makes sense. So we've got the signs down. Let's dig a bit deeper into the why. What are the main underlying causes of dystocia we need to think about?
Right, the causes. We can break them down broadly into fetal factors and maternal factors.
Just start with fetal.
Fetal causes include things like the fetus just being too big, oversized, or fetal abnormalities, so sometimes called fetal monsters, things like anasarca, which is that generalized fluid swelling, or hydrocephalus, water on the brain. Also, a prolonged gestation because a single fetus, a singleton litter, might not produce enough signal to actually trigger labor properly.
Oh.
And then very commonly issues with the fetus's presentation, its posture, like how its legs or head are positioned or its overall position relative to the mom's pelvis. Malpositioning is a huge cause.
Right.
And finally, sadly, fetal death before or during labor can also obstruct the process and lead to dystocia.
Okay. And what about on the mother's side? What maternal factors can cause problems?
Maternal causes are quite varied too. A major one is inadequate uterine contractions. We call this uterine inertia. It can be primary, meaning the uterus just never really gets going with strong contractions.
Right.
Or secondary, where contractions start okay, but then they just fizzle out or stop. This can be due to an actual defect in the uterine muscle or things like electrolyte imbalances, especially low calcium hypocalcemia or low blood sugar hypoglycemia.
Yeah.
Psychogenic factors too, like stress or fear, can inhibit contractions, or simply maternal exhaustion after a long labor.
Makes sense.
Then there's ineffective abdominal pressing, the pushing part,
Yeah.
maybe due to pain, fear, general weakness, maybe a diaphragmatic hernia getting in the way, or even just advanced age.
So the pushing isn't effective.
Exactly. Infections are another cause, things like placentitis, metritis, endometritis. Metabolic diseases like pregnancy, toxemia, or gestational diabetes can play a role. And then we have physical obstructions. Structural problems with the mom's pelvic canal, maybe from an old injury, just her conformation, or if she's too young and immature.
Like the brachycephalics we mentioned.
Precisely. Some breeds, like Welsh Corgis and the brachycephalics, are known for having a congenitally small pelvis. Other physical issues could be things like an inguinal hernia, problems within the vagina itself, like strictures, septae, tissue overgrowth, cysts, even tumors.
Wow, lots of possibilities there.
Yeah, or issues with the vulvar opening, insufficient cervical dilation, maybe just not enough lubrication. And even problems with the uterus itself, like uterine torsion, twisting or rupture, neoplasia, cysts, adhesions.
Okay, so it really breaks down into issues with uterine function, physical blockages, infections, metabolic problems, and structural abnormalities.
That's a good summary, yes.
It sounds like a really complex mix of potential issues.
Yeah.
Are there specific risk factors beyond breed that might make us extra watchful with certain pregnant animals?
Yeah, definitely. We touched on breed already. Brachycephalics, toys, Persians, Himalayans, Devon Rex. Age is another factor. Very young moms or older dams can be at higher risk.
Okay.
Obesity is a known risk factor. And interestingly, abrupt changes in the environment right around whelping time can sometimes trigger problems.
Stress related, maybe?
Likely, yeah. And a big one is a previous history of dystocia. If she's had trouble before, she's significantly more likely to have trouble again.
Right, that makes sense. So when we suspect dystocia based on history, signs, risk factors, how do we confirm it? What's our diagnostic approach in the clinic?
Okay, diagnosis. First off, in your differential diagnosis, you always want to consider distinguishing uterine inertia caused by low calcium versus low blood sugar, because the immediate treatment is different.
Good point. Hypocalcemia versus hypoglycemia.
Exactly. Then, a really thorough physical exam is crucial. Careful abdominal palpation. Can you feel fetuses? How many roughly? A digital vaginal exam is essential. Is there a fetus or membranes in the canal? How does the pelvic canal feel any narrowing or abnormalities? And check that Ferguson's reflex we talked about.
Right.
Lab work is next. At minimum, you want a database. PTT, total protein, glucose, BUN, and definitely calcium, ideally ionized calcium if you can get it.
Ionized is better.
It's the biologically active form, yeah. And just remember, pregnant animals often have a mild physiological anemia, so don't be too alarmed by a slightly low PCV. Sometimes measuring serum progesterone can add useful information too.
Okay. And what about imaging? When do we reach for X-rays or ultrasound?
Imaging is super important here. Radiographs, X-rays are invaluable. They let you assess the mom's pelvic shape and size, accurately count the fetuses, see their position, and look for bony obstructions or signs that a fetus is just too big.
Okay.
X-rays can also give clues about fetal death. You might see collapsed skeletons, bones in weird arrangements, gas within the fetus, or that balling appearance where the skeleton seems crumpled up.
Gotcha. And ultrasound.
Ultrasound is highly recommended, especially for checking fetal viability. You can directly see the fetal heart beating and measure the heart rate.
What heart rate numbers are we looking for?
Generally, a sustained heart rate below about 180 beats per minute indicates fetal stress. And consistently over 260 might need close monitoring too, could also indicate distress.
Okay, below 180 is stress.
Right. Ultrasound can also help spot placental separation, which cuts off oxygen. And you can look at the fetal fluids for meconium staining or blood, both signs of fetal distress.
Okay, so imaging is key for viability and positioning. We've got our diagnosis of dystocia. Now, treatment. What's the first step once we've confirmed it's a difficult birth?
First things first, supportive care for the mother. She needs to be hospitalized, monitored closely until all fetuses are delivered and she's stable.
Right.
And absolutely crucial, if you identified low blood sugar or low calcium, treat that immediately with IV fluids and supplements. Get those levels corrected first.
Address the metabolic issues straight away.
Yes. Now, if it looks like uterine inertia, and importantly, there's no sign of blockage and the fetuses aren't overly stressed, you might consider medical management.
Okay.
But, and this is a big, but ecbolic agents like oxytocin are absolutely contraindicated if there's any chance of an obstruction.
Why is that?
Because forcing stronger contractions against a blockage can worsen placental separation, harm the fetus, or even catastrophically rupture the uterus.
Okay, so no oxytocin if there might be a blockage.
Definitely not. In some situations, maybe with large litters or a history of inertia, some practices use continuous fetal monitoring systems, like Whelpwise. These track fetal heart rates and uterine contractions in real time.
Oh, okay.
And that data can really help guide decisions about when and if intervention is needed.
Makes sense. What about trying to deliver manually? When is that appropriate, and what are the key things to keep in mind?
Manual delivery should really only be tried if you can actually feel a fetus within the vaginal vault, within reach.
Okay, it has to be right there.
Yes. And use tons of sterile lube. Generous lubrication is essential to minimize trauma.
Good tip.
Then, gentle digital manipulation is the way to go. You want to apply traction downwards and backwards posteroventrally, following the natural curve of the birth canal.
Gentle traction following the curve.
Exactly. Using instruments like forceps. Generally really discouraged. The space is tight, the risk of injuring the fetus or tearing the mom is just too high. You can cause severe lacerations or damage the fetus.
Okay, avoid instruments if possible.
Absolutely. And never ever pull hard on the legs or tail of a live fetus. You can cause really severe permanent injuries that way.
Critically important point.
Yes. And if you have a fetus in the vault, you're trying gentle manipulation and you can't get it delivered within about 30 minutes. It's time to move to a C-section.
30 minutes of effort, then surgery.
Yeah.
Got it. So when do we just decide, okay, medical or manual isn't the way, we need to go straight to surgery? What are the clear indications for a C-section?
Right, the indications for C-section. Well, if you have uterine inertia, primary or secondary, and it's not responding to proper medical treatment like oxytocin, or if inertia is present and you know there's still more than about 4 fetuses left inside, going to surgery then often gives the better chance for fetal survival.
Okay, unresponsive inertia or lots of fetuses left.
Yes. Also, if you've confirmed there's a physical obstruction either in the pelvis or the vagina, or if you have a fetus that's malpositioned and you simply cannot correct it manually from the vagina.
Makes sense.
Evidence of fetal oversize the fetus is just too big for the pelvis. Clear signs of fetal distress, like those low heart rates we discussed, or other signs on ultrasound, and confirmation of fetal death in utero, those are all pretty much absolute indications for surgery.
Okay.
And then there's the elective C-section option. Sometimes that's the smartest approach from the start.
When would you plan an elective C-section?
Particularly for those breeds with a really high risk, or if the dam has a history of previous dystocia needing intervention, or maybe in cases with just a singleton fetus, which might be very large, or a very large litter where prolonged labor is expected. The goal there is maximizing fetal survival and minimizing risks to the mom by avoiding emergency surgery.
Proactive approach in high-risk cases.
Exactly.
So when we are preparing for a C-section, what are some key general considerations? Anesthesia, fluids?
Yeah, absolutely. 5E access and fluids are essential before, during, and after surgery to maintain hydration and blood pressure.
Standard surgical support.
Right. And remember the physical impact of that big, gravid uterus. It can press down on major blood vessels like the vena cava, reducing blood return to the heart and potentially causing hypotension.
Okay, positioning might matter too then.
It can, yes. Tilting the table slightly might help sometimes. Also, that big uterus pushes on the diaphragm, which can make breathing harder for the dam, reducing her tidal volume.
Right.
So because of that, pre-oxygenating the patient, giving 100% oxygen for a few minutes before inducing anesthesia is really highly recommended. It boosts oxygen reserves for both the mom and the fetuses.
Good prep step. Now, specifics of the anesthetic protocol itself. Are there preferred drugs or combos? Anything to avoid?
Okay, anesthesia for C-section needs careful thought, focusing on minimal depression for the neonates. For pre-medication, an anticholinergic like glycopyrrolate is often used. It's generally preferred over atropine unless the fetuses are already bradycardic, because atropine can cause fetal tachycardia.
Glycopyrrolate usually preferred.
Yeah. And definitely avoid alpha-2 agonists, things like xylazine or dexmedetomidine. They cause too much cardiovascular depression in the dam and cross the placenta, sedating the pups and making them bradycardic.
Okay, avoid alpha-2s. What about induction?
For induction, you want something fast-acting with minimal depression. Propofol or alfaxalone are usually the top choices.
Propofol or alfaxalone?
Right. Ketamine should be used cautiously, especially higher doses, as it can depress breathing and neurofunction in the neonates. If the patient is really depressed or exhausted already, sometimes a combo of an opioid and a benzodiazepine like midazolam is used, maybe with just enough propofol or alfaxalone added to get the tube in.
Okay. And for maintenance?
Maintenance is typically with inhalants, ISO or SIVO, or sometimes a propofol CRI. A really useful trick is using local anesthetic, like a lidocaine line block along the incision line.
To reduce the gas needed.
Exactly. Less inhalant means less potential depression for the pups. Epidural analgesia is another great option for mom's pain relief using things like bupivacaine, morphine, or lidocaine.
Good pain management options. What about post-op?
Post-op pain relief usually involves opioids for the dam. Just need to be aware that some amount can be excreted in the milk, so owners should monitor the neonates.
Okay. And having reversal agents on hand for the pups.
Absolutely essential. Have naloxone ready for opioids and flumazenol for benzodiazepines right there in the delivery room. If the neonates are depressed, you might need to give these, and sometimes repeated doses are necessary as the pups metabolize the drugs slowly.
Got it. Be prepared to reverse. That's a really thorough look at anesthesia, really focusing on the neonates. What about other specific meds we might need during or after managing dystocia?
Well, we already hit on treating hypoglycemia, 4V dextrose bolus, maybe a CRI, and hypocalcemia, that careful 5E infusion of calcium gluconate, monitoring the heart rate, and being extra cautious in queens due to a reported increased risk of uterine rupture.
Right, calcium and glucose.
And oxytocin, as we discussed. It can be useful for inertia, but only after correcting calcium glucose deficits. Use those small microdoses, IM or SC, repeat maybe every 30 minutes if you're seeing progress.
But don't overdo it.
Definitely not. If you need more than, say, 3 doses per fetus, or if there's still more than 4 fetuses left, it's probably time to reconsider and head to surgery.
Okay.
And just to hammer it home, oxytocin is absolutely contraindicated if there's an obstruction, fetal stress, known prolonged fetal death, or suspicion of uterine rupture or torsion. Don't use it in those cases.
Crystal clear. Okay, so we've navigated the crisis medically or surgically. What's the typical follow-up care and what's the general outlook of the prognosis?
Well, prevention is always best if possible,
All right.
right? So for those animals with known issues, abnormal pelvis, anatomical problems, hybrid risk, previous inertia scheduling that elective C-section is often the smartest, safest route.
Right.
And if you are doing an elective, timing is everything. You need to ensure the fetuses are mature enough. Basing the surgery date on known breeding dates like first day of diestrus, LH peak, ovulation time is best.
If you have that data.
If you have it. If not, then you rely heavily on ultrasound for gestational aging and assessing fetal maturity signs.
Makes sense. And prognosis after dystocia.
If dystocia is caught early and managed appropriately and quickly, the prognosis is generally good to fair for the dam's survival and usually fair for the fetus's survival.
Okay, timely intervention is key.
Absolutely. But if it's delayed, if the owner waits too long or it goes untreated for, say, 24, 48 hours or more, then the prognosis for the dam drops to poor or guarded because of risks like infection, uterine rupture, sepsis.
Serious complications.
Very serious. And sadly, fetal survival at that point is highly unlikely.
A stark reminder of the need for prompt action. What about longer term? Does having dystocia affect future breeding?
It might or it might not. It really depends on the underlying cause of the dystocia. Some causes might impact future fertility more than others.
Okay.
But it's important to note, just because a dam needed a C-section for dystocia once doesn't automatically mean she can't have a natural whelping next time. It is possible, although her risk of having dystocia again might be higher, depending on why it happened the first time.
Good to know it doesn't automatically rule out future natural births.
Correct.
Well, this has been an incredibly useful and detailed deep dive into dystocia in dogs and cats. Just to quickly recap the main points for everyone listening.
Sure.
We cover the basic definition, what normal labor stages look like, which is crucial for comparison. We talked about the key signs to look for, both from owner history and your own physical exam. We explored the many potential causes, both fetal and maternal.
Right. And the diagnostic steps, the exam, lab work, and especially the critical role of imaging, both X-ray and ultrasound.
Exactly. And then we spent a good amount of time on treatment medical management options like calcium, glucose, and cautious oxytocin use, the techniques and pitfalls of manual delivery, and then the big one, C-sections indications, surgical considerations, detailed anesthetic protocols focused on neonatal safety.
And post-op care, prognosis, and future breeding considerations.
Yeah, we covered a lot of ground.
We did. And I think the most vital takeaway, really, for all veterinary clinicians listening, is just how important prompt, accurate recognition is.
Definitely.
And then implementing timely, appropriate interventions. Getting onto it early and effectively makes such a huge difference in the likelihood of good outcomes for both the mother and her litter.
Couldn't agree more.
Yeah.
We really hope you can take this information and integrate it into your practice. And of course, dig into the references if you want even more detail on specific aspects.
Absolutely.
Okay, so on that note, here's a final thought for you to ponder as you go about your work. We talked a lot about the variability in normal labor duration, especially that really wide range in cats. So how can we, as veterinary professionals, get better at educating pet owners? What innovative strategies could we use to help them recognize those subtle but critical early signs of true dystocia needing immediate help versus just a normal, maybe slow progression of labor?
That's a great question. Better owner education there could really save lives.
Definitely something worth thinking about. Thanks so much for joining us for this deep dive.